Friends, welcome back to my channel with the new video, the part 2 on peripartum cardiomyopathy. So, in this particular short video, we will discuss the further course of our patient, which we left in the last video, and of course, the current evidences and the newer therapies related to this PPCM. So, let's continue the case. And if you remember, we actually gave her some furosemide, the hydralazine, and of course we did not give any ACE inhibitors and ARBs. So with this, and also we gave some beta blockers. So after that the patient improved with a saturation of about 94% on NIV. The blood pressures came up, and so at this point in time, the question which should be asked or addressed is whether we can continue the following treatment, or we consider adding bromocriptine, or we take the patient to cath lab. So the clear answer at this point is bromocriptine, where we start this particular drug day 2 onwards in the dose of 2.5 milligrams twice a day for 2 weeks, followed by 2.5 milligrams once a day for next 6 weeks. Uh, of course, low molecular weight heparin for anyone whose LV ejection fraction is less than about 35%. So we gave enoxaparin in this patient, and so the basis of bromocriptine is it blocks prolactin, which actually has inhibitory effect on the cardiac function, and this is very well discussed in the commentary and the guidelines of the European Society of Cardiology 2025, with the evidence of class 2A and meta-analysis showing the improvement in the LV ejection fraction from 32 to 53%, and of course there was a decrease in mortality. So the signals are pretty much clear that we need to actually use bromocriptine in this kind of patients. Don't delay, and there has been quite a few of positive signals towards using bromocriptine in PPCM. Further, we treated this patient with sacubitril and valsartan combination, that is ARNI, that is angiotensin receptor and neprilysin inhibitors. So as we know, sacubitril is neprilysin inhibitor, whereas valsartan is ARB, and we gave it in the dose of 4951. Empagliflozin, which is SGPL2 inhibitor, and spironolactone in a dose of 25 milligrams, and ivabradine for heart rate. So these are the further top-up treatment, and let's talk of the town agents like ARNI, which we actually may consider instead of ACE inhibitors. They have limited lactation data. RAS inhibitors and inhibits neprilysin and increases the natriuretic peptides. It may reverse the cardiac remodeling, and of course may have reduction in mortality. But mind you, these red circles or the red dots in front of the agents are mainly those who are contraindicated in pregnancy. So please don't give these agents when the patient is still pregnant. They can be given, or they should be given, in the patients who are perimortem in the postpartum period. So similarly, the SGLT2 inhibitors, they are emerging in the heart failures with reduced ejection fraction. Again, they have a limited lactation data, and originally were instituted in the patients who have diabetes. Because it promotes glycosuria, there is a chance of urinary tract infection, but you can mitigate this problem by asking the patient to have a good hydration, good water intake, and it may flush the kidney with prevention of UTI or the potential UTI which we may see. It will reduce the preload and the afterload. Again, it is contraindicated in pregnancy, and most of the literature which I found, there was scarce data or no data in few situations on SGLT2 inhibitors or ARNIs in the treatment of PPCM. And all of this data is kind of an extrapolation of these agents as a treatment for heart failure or DCMPs. Now, as far as the management is concerned, as we discussed about diuretics, but here I have put a yellow circle or a yellow dot, which only means that we need to be very cautious about giving diuretics and beware of the intravascular dehydration. Nitrates, yes, they are safe in pregnancy. They will reduce the afterload. As we discussed, ACE inhibitors are contraindicated in pregnancy, as are ARBs. Aldosterone receptor antagonists, which will reduce the mortality in HFrEF, but they are contraindicated in pregnancy, and we gave spironolactone in our patient in the postpartum period. Hydralazine is safe in pregnancy as it will reduce the afterload, and we gave metoprolol to our patient. Again, beta blockers are reasonably safe and acceptable choice in pregnancy, and the most important point in favor of beta blocker is it will reduce the mortality. As we gave anticoagulation to this patient for the for someone has LV ejection fraction of about 30 to 35%, and of course there is a risk of atrial fibrillation. Now it's a little debate whether to sedate this patient of breastfeeding, because it will actually eventually inhibit the prolactin, and it will have a positive effect on the heart, is still to be debated. But there are few centers who may actually advise upon cessation of breastfeeding in this kind of patients. Unfortunately, our patient deteriorated on day 8 of admission with recurrent pulmonary edemas, desaturations, with a copied mucoid expectoration. We went back on NIV. This time it was a BiPAP, noradrenaline infusion, and of course we consulted cardiac surgeon. So someone may actually wonder why we need to call cardiac surgeon, and mind you, about 10% of these patients may eventually need mechanical support, and we should be ready, at least the plan should be ready, and we should involve the particular specialist well in advance, so that if we plan for any particular invasive therapy in future, we the preparations are optimum. So as far as the genetics testing is concerned, there are multiple genes which have been identified. Predominantly, the one which we know of is TTN, and it has a fair correlation of the prevalence of this particular gene and the PPCM or DCM, and if the centers are have this facility and we need to counsel these patients on the basis of genetic testing, I would advise that you should go ahead and do this testing. Coming back to the mechanical supports, they are usually advocated in refractory shock. As we know, IABP is a bridge therapy. LVADs again as a transplant bridge, and LVAD and cardiac transplants uh, are usually considered very strongly in about 10% of the patients who do not improve at all. There is definite limitation of the finances as well as the availability of the specialty in your own hospital. ECMO, yes, if your center is ECMO registered, or ECMO program which is running, because logistics can be a problem. And our patient, fortunately, they did not need the device, and the patient actually stabilized later on. The 6 weeks follow up was the EF, which was found to be gone up. It was 42% after 6 weeks. We found that the BNP had come down, so we continued the guideline directed medical therapy. And so the literature says that about 50 to 80% of the patients may recover by 6 months. So if you look at the echo on 6 months, is the LVEF has gone up. It is 52%, so it is near total or a full recovery. Patient was on carvedilol, sacubitril valsartan, that is ARNI, and of course SGLT2 inhibitor. And so what were the good prognosis or good prognostic factors in our patient was probably the LVEF was slightly more than 25% at the baseline. We started the treatment early, say within about 7 days of the admission, and there were no malignant ventricular arrhythmias. And if at all they are present, there is recommendation of temporary wearable defibrillator in this kind of the patients. Now, talking about the poor prognostic indicators, as we should know that someone with a LV ejection fraction of less than 20% on presentation, or if the late presentation more than 1 week, and a LV-EDD of more than 65 with concomitant RV dysfunction, are clearly poor prognosticative markers where the patient's mortality is very high, and we have seen that the mortality can touch about 50% also in few patients. Now, as far as the subsequent counseling of this patient is concerned, yes, we need to actually demotivate them from the future pregnancies, the contraception which is mandatory, the OC pills versus IUDs, and the relapse risk which is to the tune of about 44%. And as I said, genetic counseling. Mind you, in many patients, we have had a significant psychological deterioration. So they can be depressed, and of course, there is a point to be discussed, which is how fast you withdraw these medicines, how you do that, when do you do that. There is still scanty data which is available, but it is actually case to case and on individual basis, where you take up one patient, you follow them up very closely, and then you may come down with the medicines over the period of 6 months to 1 year. And so, as far as our messages of are concerned, like what are the take home messages, is of course PPCM, which is potentially reversible but a serious condition. There is overall mortality of about 20%, and a standard HF therapy, which is adapted for pregnancy, needs to be started as early as possible. I would say the important message which I want to give is eco for all. And as we know that most of the gynecologists or obstetricians are well versed with the sonography or the bedside sonography which they do for the fetus as well as for the mother. You need to just extend your probe and change it to phased array probe and put it in the apex or a subcostal window to see the heart. Bromocriptine at day 2, you don't wait for that. Full GDMT after delivery. The multidisciplinary team approach will save the life. As far as possible, vaginal delivery if the patient is hemodynamically stable. LVF of more than 50%, which will be reasonably safe for subsequent secondary pregnancies. But by and large, I will refrain them from getting pregnant in the future, and of course, avoid over diuresis as it will compromise uteroplacental perfusion. So these are few of the suggested reading, and as I said, majority of my references comes from European Society of Cardiology 2025, and of course the ACC guidelines, or the AHA guidelines on heart failure. So there is important trial by the name of Rebirth trial, which is already started, focusing on bromocriptine in the use of the PPCM. The results will be out somewhere in 2028, so we will have to wait and see. But at today's point in time, there is an adequate evidences to say that we need to initiate bromocriptine in this particular patients group immediately or as early as day 2, and we may continue it for 6 weeks or 4 weeks later. So that's all for now. uh, Thank you.